Good afternoon, everyone. This is Robert. So excited to get started today. We're going to give folks a little bit to chime in. We have a good amount of registries, so we're going to let folks join us in the next couple of minutes. We'll get started probably at 12:02, 12:03. We'll see how folks get in. So we'll sit tight. Good afternoon. So again, we'll get started in just a couple of minutes. Thank you guys so much for joining. We'll get started at probably about 12:03. We're going to give folks a couple of minutes to join. Should probably, I'll add a slide that says that. But again, we'll get started about 12:03. Definitely feel like I need some elevator music at this point, but I will spare you guys any singing or humming over here. But we'll get started in just one more minute, y'all. Thank you for joining. All right. Well, thank you guys so much for joining. As promised, I do want to get started on time. We have a pretty good group of folks that are registered for today, and thank you all for joining us. Lots of stuff to cover. So today we're going to be diving into compliance with 42 CFR Part 2, the final rule. I'm sure that those words excite everyone as much as they excite me, and so I promise to try to make today as entertaining and fun as we can while we work through some federal policy. But this stuff is very important, as everyone knows, and obviously has a very significant impact to the care that we provide to members and caregivers, as well as to make sure that we're remaining in line with all of the requirements we have. So quick, copyright thing, content is ours. If you would like to use it, please reach out to us. We are more than happy to share. We just like to know about it. So if there are any components of today's presentation, or if you're interested in us coming and doing it again for you and your team, just let us know and we'll be happy to coordinate. For those that may not know much about us, I'll let you guys peruse the website. I'll spare you the conversation today. But we've been around for about 20 years, and we specialize in helping health and human services organizations based here in Arizona, but also work nationally. In addition to today's presentation, we do a couple of community-focused things that are designed to help support health and human service providers, again, in Arizona as well as nationally, but locally, we do some networking events. So coming up in a couple of weeks, we're going to be having another networking event. Also happens to be my birthday, so we're going to spin that in there. And the real thing that we'll be celebrating that day, in addition to that, is also the fact that we just achieved our 501(c)(3) status for the health impact community. So this is our charitable arm of the organization, which we're super excited to have that status to continue our mission to give back and serve. And along those lines, in a couple of weeks, we'll be volunteering. So we do a volunteer event once a month. Would love to have you and your team join us if you are so interested. We post all this stuff on our website so you can check it out. And of course, we hope that you will join us sometime in the future. In addition to kind of those in-person networking and volunteering things, we do host these power hours on a monthly basis. So today's topic, of course, is 42 CFR Part 2. Next month, we're going to be partnering with a customer that we've done some work with and talking about innovations in justice reentry services and some innovative stuff that they're doing around social determinants of health, which we're really excited to kind of spotlight and highlight the work that they're doing. And then we also have mastermind communities, which offer group technical assistance to organizations. They're convened around specific topics. So we have two groups that we are looking to get started. The first one is around clinical records documentation, which of course has a compliance lens, somewhat related to today's conversation. And the other is around business growth and development, helping organizations build their capacity for their sustainability and growth. So we're really excited to offer those. Of course, you can check out the website to get some more information about that stuff. A little bit about myself, for those of you that don't know me. So I have actually, it's 25 years in health and human services now, so I got to update that. But excited to be here, based in Arizona. I've done lots of great work locally, and then again, had the opportunity to work nationally with some organizations. So hopefully that breadth and depth of knowledge will benefit today's conversation as we continue. So the intent and goal of today, first, we're going to provide just a brief history of what 42 CFR Part 2 is. I think anyone that works in substance use services, treatment, is familiar with this. For most of us, it has likely caused an administrative burden over the years. And so hopefully the content we're going to cover today will help illuminate opportunities for that by diving into the requirements of a new final rule. So the final rule was actually written in 2024, but it went into effect already in February earlier this year. So in the noise of everything that's going on, we hadn't really seen enough education and awareness about this topic, which is why we wanted to host today, even though this rule has already gone into effect. It's something we definitely want to dot our I's and cross our T's on. And through that process, we'll talk through how you can kind of self-audit your organization to understand the impacts of the final rule, and then how you can address implementing those services. Before we get going, of course, just want to provide a disclaimer. While I have worked in this industry for 25 years and definitely have done my fair share of policy interpretation and work, I am not an attorney. And so if any of the content today is, triggering some thoughts or making you want to rethink and consider some of your processes and or revisit any of that work, the information that we share and provide is definitely a solid first draft for you, but it's definitely something you're going to want to consult with your internal legal counsel and or compliance officers around, just to make sure that they are fully bought into the protections and support that we cover. All right, is everyone ready to get going and dive in? If you don't mind, let's do a little interaction. Give me a round of applause if you guys are ready to go, or a thumbs up. I just want to make sure you're all haven't walked away on your lunch break today. All good. All right. So let's talk about the history of 42 CFR Part 2. So this is not a new requirement. Most of us, actually, I was not aware it had come into effect in 1975. It's older than I realized, but ultimately, what 42 CFR Part 2 was designed to do was to protect individuals who have substance use conditions by partitioning out and adding additional protections to their medical record data, their protected health information. And so historically, what this resulted in was anytime this data was collected, individuals would have to keep it in a separate part of their record. Whenever there was a medical record request, it would have to be, very explicitly excluded, from those requests. And I'm sure we all remember, very stringent requirements over time that came into effect that required, this data can only be shared with this person on this date for this purpose, which really from a care coordination perspective and the ability to be able to support individuals as they move through the crisis system or have multiple levels of care or receive care at multiple sites concurrently or within very short time, it made it challenging sometimes to be able to share this information. And so, which could be very relevant, of course, to their treatment. So you can see, there's been lots of updates and amendments. This actually is not all of them. It's been tweaked constantly, over the last, what are we going on, 40 years here. And so, 50 years, actually. I think that would be 50 years if I can do math today. And so as it has evolved, there was definitely the need to take a new brush to it. And so looking at what the final rule states, again, the final rule was passed in 2024, but we were given 2 years to implement the final rule. And so the original goal, or essentially what the rule said, is that the federal government ordered itself to essentially align or do its best to come as close as it can to align 42 CFR with the existing HIPAA requirements for patient information, privacy, and governance. And so when the final rule was written in 2024, again, they were, given 2 years to implement. In 2025, last year, they started publishing they started putting the pieces in place for them to be able to enforce the requirements of this rule. And those rules became enforceable on February 16th of 2026. So again, the rule has been around for 2 years, but the enforcement of the rule has just gone into effect a couple of months ago. And that's, of course, the importance of today, making sure that we are all in compliance now that the final rule is in full effect. And so what does this final rule say? What are the requirements or what is the language that we need to be focusing on? So there are a couple of different components, and there's kind of an interesting question to decide or determine if your organization even qualifies as a 42 CFR Part 2 provider. And so you can see here that a Part 2 program, as it is described in the statute, or the rule, excuse me, a Part 2 program is someone that provides treatment and rehabilitation, someone that includes employee assistance programs. These can be programs within general hospitals. They can be school-based programs. They can be private practitioners. But the real kind of linchpin for us is whether or not these organizations or individuals hold themselves out as providing substance use diagnosis, treatment, or referral to treatment. So I think for some organizations, especially if substance use disorder screening, diagnosis, treatment, referrals, if that is a core part of your business, then it's probably, pretty easy for you to identify, that this probably applies. For organizations such as FQHCs or primary care practices, emergency departments, hospitals, primary mental health facilities that might not be a primary substance use facility, there is definitely kind of a little bit of a shade of gray on whether or not this rule applies. And so forgive me, I should have had this part highlighted for us. So it's these two different kind of linchpins or pillars of the criteria. If we receive federal funding or if we are federally assisted, that definition of federally assisted also includes, like, if you are a nonprofit organization, you are considered federally assisted because of your tax exempt status. If you are an FQHC, of course, it's going to mean you probably receive Medicare and Medicaid money, but there are a bunch of different ways that the term federally assisted gets interpreted. And then again, that second criteria is if you are federally assisted and you hold yourself out, that is where these rules would apply. You'd be considered a 42 CFR Part 2 program. And so we can see that unpacking that holds itself out as there's a couple of different ways that that gets interpreted. So if there is a person within your organization that is specific to this, so that could be a job title or their credentials. If there is an identified unit, if you had a detox unit or a substance use treatment unit or a department, that would also qualify as holding yourself out as. And then we get into individuals whose primary function is the provision of substance use disorder treatment. So if you have a peer support specialist, but a majority of their function and role is addressing substance use, then of course this criteria would apply for you. Where this does, again, have some shades of gray is in general medical facilities or general healthcare facilities, where, again, like an emergency department, while you may have someone that comes in off the streets that is intoxicated and needs substance use treatment, that may not be your primary focus. That may be a sub-portion or a smaller proportion of the population you serve. Similarly, FQHCs also apply. A primary medical practice may apply, where PCP, again, may serve or treat someone that has a substance use disorder, but it's not their primary focus. They're not, certified or licensed or any of those things. It's within their approved and allowed scope of practice, and it happens. So that's why the shade of gray is there. So what do we need to do in the event that we are that 42 CFR Part 2 program? So there are some updates and changes in the rule. So it does allow, specific to patient consent, it allows for single consent, which is different. And that consent no longer needs to be itemized and individual to the specific, person, purpose, and time frame. That consent can, similar to and aligned with the HIPAA rules, can be used for future uses and disclosures. It does allow individual HIPAA-covered entities, as you can see here. So like if I received substance use-related or Part 2 data from another organization and that consent is in place, then we can actually reshare that data and those medical records, whereas historically under the old rule, that was not allowed. Other things that are allowed to be done. So when doing your standard coordination of care and treatment, payment and operations of services, it does allow you to disclose information like with a health plan or with another covered entity that may be needed, public health reporting, vital statistics reporting, all of that type of stuff. So again, it's loosening the historical restrictions or the administrative requirements over this data and allowing organizations, again, moving it closer to analogous to HIPAA requirements, is allowing organizations to coordinate care on behalf of individuals that may have substance use conditions and or data in their medical records. And you can see it also aligns the penalties. So there's the big overarching goal and direction, as I mentioned, get 42 CFR Part 2 closer to alignment with HIPAA, which I think a lot of these things get us there. It's not fully aligned, it's not synonymous and exact, but we're definitely getting closer. Additional requirements of the new rule. So they also aligned breach notifications. So whenever there is a HIPAA violation, or if there were a data breach, if a laptop got stolen that had protected data on it, if there were a cyber attack or a hack or any of that type of stuff, under those circumstances, there are requirements for breach notification. Again, there used to be separate requirements. Now they're bringing them together. And that also includes patient notice. So whenever we are disclosing or getting consents and notifying patients of their rights and privacy practices. There's some updates that need to go in there. And then this last part I thought was really interesting, maybe just because it's not something I work in a whole lot, so maybe that's why it was a little bit newer to me. But a lot of nuance in safe harbor rules, and very specifically around like subpoenas and judicial requests for information. And so in essence, while there are some loosening of restrictions around sharing Part 2 data for care coordination, treatment, payment, and operations, they continue to retain the protections and safe harbors and privacy when it comes to subpoenas and disclosures from judges, law enforcement officers, things like that. So we're still, prohibited from just handing over information at the request of a law enforcement officer. And even when it comes to a court order, they are still required to very explicitly state not only what data they're requesting, but also the purpose of the request on that court order. And so you can see here that those requirements maintain or still hold. I know we're going through a lot of stuff, and so I've got to pause in about 2 seconds or 2 more slides, but why don't I pause here just for the sake of conversation? Any questions so far as we're going through? I know there's a lot of content and it's fairly rich or nuanced, but how's everyone doing? Give me a thumbs up, give me a high five, a heart, show me signs. All right, we're holding on. I love it. Thank you guys for riding with me. Okay, so as we mentioned, there's some new requirements and clarification around safe harbor and how that information becomes available, including under judicial review and during investigations. Big news, and this is a big deal for a lot of providers, and then folks who work in interoperability and health information exchanges and EHR technology and everything. Historically, data had to be segregated or segmented. That is no longer required. So where we used to have to keep Part 2 data kind of locked away in a separate part of the record that was not accessible, that is no longer the case, which, I think a lot of health IT vendors are probably clapping their hands and applauding. And additionally, same things kind of come through around complaints. So folks still have the ability to file complaints and make those specific to the way that their Part 2 data is shared. So that is a new addition, allows people the additional protection for that. And then this last piece is also very interesting, and it's kind of a newer element. So substance use disorder counseling notes, they are the way that they're defined in the rule is these are essentially the clinician's notes to self. So they are not, a reported history. It's not a progress note. It is not, a DAP note or a SOAP note or any of those things. These are the insights, of that psychotherapist or counselor, a substance use therapist, excuse me, and their observations of the condition or of the symptoms that individuals are articulating in their sessions. And so what the new rule does is it formalizes SUD counseling notes, very analogous to what HIPAA has protected in psychotherapy notes. So similarly, from a medical records procedure, when someone submits a medical records request, psychotherapy notes are typically held back and are not shared. They are not disclosed because, again, they are the clinician's notes to self, not a part of the patient's history or diagnosis or treatment records progress notes. So SUD counseling notes now have that same protection and that same option for individuals. But there's a nuance here. Providers are not required to use SUD counseling notes. So this is only if you choose to use counseling notes, or excuse me, SUD counseling notes, then you have this ability to withhold them, but you are not required to use SUD counseling notes. All right, last slide, and then we're going to take a real pause just to kind of see how folks are doing. But so then we get into some of the other nuances around patient consents. And so again, there continue to be restrictions or protections around combining patient consents when you're looking at the various purposes of those. And then you can see here that in the event, because those SUD counseling notes are partitioned out or are preserved, that you would need to do some specialized targeted things or targeted consents if those were to be shared. And then, of course, patients need to be notified whenever that information is disclosed or shared. And that, again, aligns with HIPAA. So those are things that largely providers should be familiar with. And then again, just another random, I feel like this one's a little bit outside the scope of medical records, but for whatever reason, part of this is that patients have the right to opt out of receiving fundraising communications. It's part of the rule. I don't combine fundraising communications with medical records in general, but I'm glad that folks get the chance to opt out. All right, so that largely covered what the final rule was. So I do want to take kind of a little bit of a meaningful pause here and see if this is resonating for folks, what kind of questions may be coming up based off of the work that you're doing, based off of your experiences. Is there anything that's standing out to you as curious or alarming? Are your organizations already kind of implementing and well on the path through here, or just kind of, I just want to have a little bit of a dialogue. Um, Anyone have any comments they want to share? Okay, all good. Well, we will continue moving forward. And so what we wanted to do is recognizing that, I don't know if that was just me, but, I definitely have felt like this has not gotten a lot of attention. There's so much going on in health and human services today. And so I definitely feel like some organizations may not have fully been aware, of the requirements and the timeline and the fact that these things have already gone in place. And so that's why I wanted to provide an opportunity or kind of a roadmap for folks to do some self-auditing, double check internally where things are at, and then, of course, make those revisions as needed to any current practices to make sure that we're fully compliant. So at a high level, what the self-auditing process could, would, and should look like is, you want to, of course, do an assessment and figure out, compare, right, what the new requirements are with your existing policies, procedures, practices, training content, marketing communications language, if that applies for you. There's quite a bit of stuff that can go into that, and we'll cover those details in a couple slides. Then we want to go through kind of a risk management, risk identification process, right? Score those risks, figure out their likelihood, their impact. Then based off of the risks that we've identified, figure out, what is the appropriate strategy that we want to follow, and then, of course, implement those strategies. And you can, add monitoring and turn this into a cyclical process, of course, if you would like to. I think that after kind of the initial phase, the recommendation, of course, would be to move this into your ongoing, existing compliance program monitoring and or your quality program monitoring as appropriate. So let's unpack this a little bit more. What do each of these steps kind of look like, and what could they include? So for the self-assessment, there's a bunch of stuff you want to look at, and some of it is not as intuitive as may be off the cuff. And so looking at your corporate status, again, if you're a nonprofit 501c3 organization, that immediately qualifies you as, an organization that is federally assisted. So that's an important kind of contingent component. If you're not a 501c3, thinking about other structures. Your licensure, if you're an FQHC or an RHC or one of those federal designations, and that would meet the criteria or the threshold. Looking at your accreditation, other things that basically looking at the way in which you are connected to and or related. When we're looking at accreditation, looking at, is there a substance use accreditation? Is there a specific license to provide substance use disorder treatment? All of those things, again, are going to help you flag, am I federally assisted, and am I holding myself out as providing substance use treatment? health plan contracts, if it's in your scope of work, that you're providing substance use treatment, then this is probably a yes, right? Your staffing plan, if you have medical doctors that are board certified in addiction medicine or licensed independent addiction counselors or therapists, or folks that hold very specific credentials, job titles of substance use therapist, or even recovery support partners, like a peer support, recovery support. All of those things, again, are going to help you basically land in this box or in the definition and criteria as holding yourself out as providing substance use treatment. Staff credentials, I think, probably is apparent in some of the other examples that we provided. But again, if you have that board certified folks or someone that has advanced training or any of those things, those are things to consider and contemplate. If your EHR is, full of substance use screening tools, your, ASAM assessments, all of those things, by and of itself, that does not immediately put you into the category, but it's definitely something to think about. Have we built out an entire arm of our EHR or portfolio, to address substance use disorder treatment or nuances or specialization in there? Then that may, again, kind of indicate that we're being very intentional around providing substance use services, and therefore something we may want to, or something that may qualify us as this organization or in this space. But then we get into, again, non-traditional stuff. Your website, your social media, provider directories, if you are listed in addiction treatment referral directories, if you're, listed on social media as a substance use provider, if your website has entire pages dedicated to this, even looking at press releases and media coverage, all of that stuff matters because it has to do with how you are communicating to the public about the services that you offer. So again, if you're that general mental health facility and you're not clear if you fall under these requirements, and if you don't want to fall under these requirements, then these would be potential risks for you to flag and then, of course, implement mitigation strategies. Looking at the proportion of your claims, your patient diagnoses, is again going to get you to understand like what proportion of our services are substance use related. For some organizations, it's going to be 100%, right? For those general medical facilities, it may only be 5% or 2% or 1%, right? And so having an analysis is going to help you understand, again, whether or not you fall into this category, and will inform kind of your implementation steps. And then I've also seen some organizations that, they might have been totally clear in all of these areas, but they submitted a grant to help them, run a substance use treatment group or do harm reduction campaigns or even naloxone types of things, to where it was very clear that they were, holding themselves out to do substance use treatment services or referral screening, those types of things. And then it may behoove you, this is not required, and it's all of this, you can tell this is a pick list, so it's designed to give you ideas on, based on your organization, what you may want to look at. Obviously not, a mandatory checklist, but just something to react to. And if you're still not sure, or if there are still shades of gray in your process, taking some time to interview some key folks, including your compliance officer, quality management team, medical director or officer, chief clinical officer, marketing communications, PR. I think even human resources and training folks may have some insight into, how much are we providing training on substance use related topics, all that type of stuff. So again, the assessment process can be as thorough or as simplistic as you want. And for some organizations, that you're a substance use organization, so you can probably skip the assessment process altogether. And so this is a decision tree that you can see that the Legal Action Center, which is a technical assistance group that is funded by SAMHSA to help support the rollout of this new rule, the final rule, they helped develop this decision tree. And again, just for some organizations, this is going to be so, obvious that you don't need a decision tree. But if you are that FQHC or general mental health facility that is not clear or not sure, this can help you analyze and assess your organization. And again, feel free to look at that assessment roster to kind of see where those things may apply. And so that first criteria, are we federally assisted? Here are some examples of what those things may look like, or ways at which you can ask and answer that question. Of course, if you answer yes, then you probably are federally assisted, or you would meet that criteria. Therefore, this would apply for you. That second criteria of do you hold yourself out? This is where, I think this is kind of a more drill down of a lot of the things I've been anecdotally describing throughout today's presentation. So I won't reread all of it, but considering, again, your scope of services, your licensure, your types of facilities, your levels of care, who your staffing matrix is, different, ways that you may be identifying substance use as a priority, even in your strategic plan. I was doing an audit with one organization and they're like, nope, we don't think that we're going to qualify as this. We won't fall into this criteria, but in their strategic plan, they had made a commitment to increase, is very specific to addressing substance use disorders within their maternal health program. So they were thinking about it as like, well, that's just our OBGYN line of business. There's not a lot there, but then, they had made this focus priority in there to make sure that they could screen better for substance use and do SBIRT and things like that in that program. So lots of little nuance in there. But so for organizations where this is a shade of gray, hopefully this checklist helps identify that. Considering, again, more of some of the marketing things and some of the non-clinical stuff, the way that your communications are set up, again, I think we've covered a lot of this already, so I'll move pretty quickly through it. And then getting to that final kind of conclusion, after you've checked all those boxes and done that process, if you've answered yes to any of these, then, you would identify whether or not you meet these 2 criteria. And so what do we do from there? So risk mitigation planning has a couple of core principles behind it. So in risk mitigation planning, you basically are left with 4 different options. Those options are to avoid the risk altogether, which might mean shutting down a program or, never offering substance use treatment services or just, running away from this as far as you can, as fast as you can, right? There's also efforts and work that you can do to reduce your risks. And so looking at ways in which if you are if you are, doing community outreach or street outreach or in your marketing programs, you're really addressing behavioral health, finding out ways or looking at how we can potentially still address substance use needs, but not call it out as a primary focus or as a primary need or service line where it becomes more secondary or ancillary. There are options and ways that you can do that. Transferring your risk. This would be a great way. Again, if you're an organization that doesn't want to fall into this category and doesn't want to work in these, meet these requirements, you can transfer this risk ultimately through like partnerships or co-location or different ways that you might be able to, where it's not under your entity, getting another entity or another organization to kind of take on that burden so that you as an organization don't fall under that criteria or aren't required to meet those expectations. And then the last option, of course, is accept that risk, right? Like we're a 42 CFR Part 2 program. There's no doubt about it. We definitely are going to fall under this category. And again, I think for some folks on this on our training today, that probably was immediate for you, right? When you're like, yeah, this is us. This is going to apply to us. And so if acceptance, is the course and the path that we're going down, then we need to make sure that we're coming into full compliance and that we are implementing all of the requirements to make us whole and reduce the risk to the organization by implementing the requirements of the program as stated in the final rule. Any questions about kind of the self-audit process or even this risk management component? We're making really good time today, so we're going to probably wrap up early if there aren't a whole lot of questions for us. Anything else? Okay, cool. So we're going to move into our final phase, which is around implementation planning. And so in the implementation planning, we are assuming that, yes, we are a 42 CFR Part 2 provider, and that we need to implement these requirements so that we can come into compliance with the final rule. And so if there are, any areas through that risk mitigation process. If there were any things that, you did decide or did want to opt into, you want to incorporate those into your implementation, right? But outside of that, assuming again, you are accepting, I am a 42 CFR Part 2 program and I need to meet these requirements. What do I need to do? The first thing you need to do is go through your policies and procedures. There are some specific things called out in the final rule. So like your patient's rights has to be updated. Your patient consent forms need to be updated. If you are going to have that SUD counseling note, then you need to, of course, create content to describe what that is and train people how to use it if it's a new program for you. Build the form out into your EHR, make sure that it's accessible, make sure that, there's pre-configured workflows to keep that information segmented and additionally protected so that when you export a medical record, it doesn't include those in there. You definitely want to make sure you think through all of those little nuances based off of your EHR and how it's configured. But we also want to update, records maintenance policies, the custodian of records procedures. So as you guys know, Medicaid, records get held for 7 years, or if, the patient is under the age of 18, then is it 7 years after their 18th birthday? There's that can be a long time, right? For folks serving Medicare, you got a 10-year, records retention policy. So making sure that folks understand, what the future impact of that is, so you can stay in compliance there as well. Updating those notice of privacy practices. So again, you want to see all this updated language baked into those notice of privacy practices. This would mean that all patients, all members, all clients, everyone that you're serving needs to sign an updated notice of privacy practices. So it's not just the new ones for new admits or new patients coming in. You would want to go back and all active clients and patients, you would want to have them sign a new updated notice of privacy practices. Same thing goes with your 42 CFR Part 2 consent forms. So again, historically, these forms were so itemized and individualized, and there was a lot of requirements on what was on the form and how they were used and how frequently, and then based off of that, how they could be deployed. And so since those things have changed, we'll need to go back and update those forms, but also, retrain the staff, making sure that they know exactly how to use those forms and what those changes are. And then once you have your policies and procedures and all of these forms updated, obviously, you really do need to train any staff member that is, patient focused or customer focused, that is out there, so that they know how to respond. I think that we all, understand the way that HIPAA often restricts our ability to communicate and convey folks. So again, this talks to like your MA, your scheduling desk, your intake folks, your medical records team, your clinicians, if you're serving, case managers, peer support specialists. Everyone needs to understand what these new requirements are, so that we don't violate people's rights by declining to participate in them, but that also that coordination of care, continuity of care, case management, all of that stuff can move more smoothly. The intention and the purpose behind revising 42 CFR Part 2 was to make our lives easier. At least that's my 2 cents. That's my read on it. They are trying to make it easier for us to meet the needs of individuals with substance use disorders. And so let's not hold on to old rules that may be adding, administrative barriers when we, have a little bit more flexibility now than what we used to have in the past. And then finally, of course, this is something, as turnover happens or as we expand our programs and hire new staff, we're going to have to continually, revisit this, stay on top of it and track it. And so that monitoring adherence post-implementation, this should live in your compliance program. Organizations are required to have an annual compliance plan, a compliance officer, compliance committee, and making sure that that group of folks are reviewing those policies and procedures, staying up to date on the final rule as it changes and continues to get tweaked here and there over the next couple years, etc. All right, everyone, that was it for today. Like I said, we got through this pretty quickly. I'm a little surprised. And normally I'm very much more long-winded. And so if you will, please take a second, take out your phone, scan this QR code, fill out our satisfaction survey or our experience survey. Would love any feedback that you guys are able to provide on the content, delivery, all of those things. And then, as I mentioned, we are having some upcoming stuff, some cool, fun events. So not this Friday, but next or the 15th. So in 2 weeks, Friday. Oh yeah, today is a Friday. 2 weeks from today, we are going to have a networking happy hour. We would love to have you there. It's free. We cover the tab. So please make sure that you come on down, bring a friend. We would love to see you there. The following Monday, we're also doing our volunteering event with Nourish Phoenix. We'll be compiling food boxes for folks. And we're really excited to have as much help as we can as we seek to support the community. And then, of course, next month, join us back for same time, same place. First Friday of the month for your lunch hour. We're going to be with Scottsdale Recovery Center talking about innovations in justice reentry and social determinants of health. So super excited about all of that upcoming stuff. Check out our website. It's all there. Wanted to give you one more chance with this QR code, of course, and then open the floor for questions. Were there things not covered today that folks thought or expected or anything that I can help you with while I've got you? All right. Well, sounds like this one was short and sweet. So really, really thankful and grateful for each and every one of you. And I hope that you guys have the great rest of your day and weekend, and we will be talking very soon.
Good job, Robert.
Thank you.